the deficit and the debt in the long run, the best thing it could do would simply be to recess and go home. Right? The congressman said, we are all terribly worried about the deficit and the debt, and so we can't run the risk that we will pass laws that will increase it. They simply recess, they go home, no problem. That's not what they want to do. They want to stay in session and continue to pass laws, but they also want to pass laws that will in some way constrain their ability to pass deficit-busting laws in the future, which is a very hard problem, because how can one Congress possibly bind its successors? That whatever this Congress passes, its successor can immediately undo. So if the next Congress says the people coming after us are not allowed to increase the deficit, the subsequent Congresses can then repeal that and say, oh, well, yes, we are. You should have done something actually real rather than just telling us what we could do back when you were in office. So that's the worry, and that's the worry that allows an S&P announcement on Monday morning to knock $150 billion off of American wealth. And as I said this before, this worry is overwhelmingly driven by the tremendous disjunction between the costs of healthcare in the United States and the cost of healthcare elsewhere, coupled with the fact that the United States government pays for half of all healthcare spending in the United States. Privates pay for half, the U.S. government pays for half, so the fact that we spend 3 times as much on healthcare as an industrialized country with our life expectancy has a major impact on the federal budget, and an impact that we all expect to grow over time. And as I said before, we're not only more expensive than other countries, we have enormous variation in spending across our country, enormous variation that doesn't seem to have any relationship to quality of care, or to life expectancy, or to pretty much any other medical outcome number. And this suggests that our healthcare spending is broken, and since half of all healthcare spending is done by the government, this affects the government budget as well. If we continue to spend 3 times as much as other countries with our life expectancy, that's going to be an enormous burden on Americans, which will ultimately have to be resolved either by raising taxes a lot, or by some inflationary episode to wipe out our debt, which would then still leave us with the same problem because our healthcare costs would still be high. And as I said last time, we have our 4 big questions. Why is U.S. healthcare spending so much higher? Why is U.S. healthcare spending projected to grow so rapidly? Why are we getting so little for our money? And what should the federal government do about it? And last time I got through differences with other countries. That is that we pay our doctors a lot more. We pay our specialists a lot more. We allow our specialists to control the rates at which Medicare reimburses people for procedures. And that seems to carry the rest of the system with it. That is Medicare. Medicare used to pay, back before the Reagan administration, or even into the Reagan administration, Medicare used to pay doctors and hospitals what they asked. They weren't that stupid. They didn't say, we'll pay you whatever you ask for treating this Medicare beneficiary. They said, what do you pay people who don't have Medicare? What do you charge people who don't have Medicare for this procedure? And document that, please. And then we'll pay it. And for Medicaid, they did much the same thing, except that for Medicaid, it was, well, we'll pay you 2/3 of what you get for treating private patients with it, because these are poor people you're treating under Medicaid. And you agree that it's the government's responsibility to pay for them, but we don't feel that we should pay the full amount that you get from a private patient. And come the 1980s, the Center for Medicare and Medicaid Services, the Department of Health and Human Services, get very anxious about this. We're just paying people what they ask or what they charge others. Decide this isn't a very good business. And so they create the DRGs. They divide up all the possible things that you might have done to you by a doctor or in a hospital that Medicare would pay for into little categories. Appendectomy, right? Heart attack, blocked artery, say bursting aorta, when your aorta bursts because of high blood pressure or whatever, lung cancer induced by smoking. And they say, we are going to classify every single Medicare patient who you treat as one or more of these DRGs, and we are then going to pay the amount that's appropriate for your region, for your local costs for each DRG. And thus hospitals and doctors that manage to treat people fairly successfully, they'll make more money than doctors and hospitals that find it incredibly expensive to treat a given DRG, and this will create incentives for hospital efficiency, and so on and so forth. And it worked kind of so-so. That is, on the one hand, it does put the incentives where they are, or where they ought to be. On the other hand, if someone's admitted for, say, a knee operation, and while they're in the hospital recovering from the knee operation, suppose they catch pneumonia. Well, you either keep them in the hospital and treat them for pneumonia, and then they leave, and their disease and their treatment was knee surgery caused by knee surgery necessitated by a loss of mobility, and it was really expensive to treat them because they caught pneumonia while they were in the hospital, in which case the hospital loses money. Or the hospital can discharge them and then readmit them the following day with galloping pneumonia. Aha, a whole new DRG. We get to bill Medicare for both of these. We make more money. We've harmed the treatment of the patient by leaving their pneumonia untreated and by discharging them and only picking it up when they come back in when the disease is more advanced. That's not a terribly good thing to do. That's the kind of thing that emerges when you have this kind of bureaucratic reimbursement system. And so the economists looking at this tended to say, ha, look at the stupid socialist centrally planned government. Look at how it thinks it can centrally plan things. How it thinks it can take all the Medicare patients and all the diseases and slot them into individual slots and pay the same amount for each one as if individuals were eggs, extra large, large, small, whatever. Wouldn't it be more efficient to have the private sector and the magic of the market and the price system working as a Hayekian discovery system managing this? Surely the private insurance companies have a lot better system of reimbursing doctors and hospitals for their patients when they treat them. Let's find out what it is. And what we found out was as soon as Medicare showed up with the DRGs, all the private insurance companies said, what a great idea. How wonderful. No, we don't have to do a huge amount of work in figuring out exactly what we should pay for people when doctors treat our patients. We'll just say we pay Medicare plus 5%, or we pay Medicare minus 10%. Give us your DRGs, and we'll then pay you, and we're going to attach our payments to Medicare. We're going to free ride upon the great information gathering effort that Medicare and the Center for Medicare and Medicaid Services are doing. And so rather than performing a superior, more flexible, market-based alternative to this exercise in kind of central reimbursement planning, the private insurers, by and large, all went along. And then, of course, things got worse, because how do you decide what should be paid for each DRGs? And the answer for the Center for Medicare and Medicaid Services was to get a bunch of doctors together and have them argue. And they decide whether an appendectomy is worth half a hip, is worth half an ACL replacement, or one ACL replacement, or 2 ACL replacements. And then the committee of doctors comes up with recommendations, and the director of the centers rubber stamps it, and the Secretary of Health and Human Services rubber stamps it. The problem is these committees were then relatively rapidly captured by specialists. because specialists are the people who know most about each individual disease. And so if you have a committee where there are 8 general practitioners and 8 specialists, well, one of the specialists will really know about the disease, and they'll have a view. And their view is that it's really expensive, hard to treat, and requires enormous amounts of reimbursement. Because I, as board-certified specialist X, deserve 3 times as much money as you, internist or general practitioner, who didn't go through all this extra training. Therefore, what I do deserves to be reimbursed at a much higher rate than what you do. And that's been our system of DRGs more or less ever since, which is one reason why in Berkeley it's incredibly easy to find a specialist, and rather hard to find a normal doctor, a normal internal medicine doctor. You know, why specialists will take you and will give you same-day appointments, while it's a schlep to get a general practitioner to see you or an internist to see you. And indeed, one of the big pieces of the Affordable Care Act is this Independent Payment Authorization Board, which is designed to be a bunch of people who aren't, say, necessarily in tune with the specialists, to give them control over the DRGs. So that's where our more and better paid specialists come from. As I said, we have higher doctors' earnings, in large part because we gave the American Medical Association control over the number and the standards for medical school admission, which, among other things, means an awful lot of people at Berkeley are taking organic chemistry courses, which they actually don't need to know very much about to be a doctor. That organic chemistry is either much too much or much too little, and to require that every future doctor have it and do well in it makes little sense. We also have defensive medicine, malpractice, and even more the worry that you might be accused of malpractice. And we also have increasing market concentration. As I said before, the University of California is attempting to get into a fight with Sutter Health, and I think the University of California is going to lose. It's going to be unable to get Sutter Health to lower the prices it charges UC for treating UC faculty and staff, because Sutter is simply too big. And they can't credibly claim that we're offering full health benefits if you can't go to a Sutter hospital. Now, the nice thing about all of these is there are things we can fix. We can use antitrust policy, or we can establish public options, say a Medicare Lite program that the government would run, or simply let people sign up for the Federal Employees Health Benefit Plan to diminish market concentration and thus the margins of hospital chains. We could reform our system of malpractice so that it would work as a thing that makes the lives of people for whom horrible things have happened in the hospital somewhat easier, rather than what it is now, where you have to go through an enormously expensive legal process to find some guilty doctor who did something clearly wrong. We can reform our public incentives that have led us to more and better paid specialists than anywhere else in the world. We could even reduce our doctors' earnings by replacing them with nurse practitioners and nurses, and restoring doctors' place in the earnings hierarchy to something much more like it is in Western Europe, or something much more like it was 2 generations ago. I remember reading a book by a Dr. Lewis Thomas about how when he went into medicine, I think at the end of the 1930s, everyone told him it was an extraordinarily rewarding career, and the best of all, but don't expect to get rich doing it. That the hours are long, you have to make house calls, but your patients can't pay. Those who do pay late. That the view that the doctor is the upper class of America is a post-World War II emergence, and it's not something that's necessarily the case in other countries. We probably can't do much about larger pharmaceutical profits, precisely because other companies are free riding upon the profits that we offer, drug companies. But we could reform our system to make pharmaceutical profits, say, more focused on diseases that actually matter, and less focused on male baldness and impotence cures, which at the moment attract a huge amount of our drug money, and probably we don't really want to spend so much of it quite there. Huge numbers of administrators in insurance companies. Dealing with that's a big problem as long as we want to retain our private insurance system. And maybe we do. Market competition has advantages. But in the case of a market like healthcare, where a whole huge amount of the game is figuring out which people are likely to be sickest and figure out some way to charge them more or not to cover them, you're going to have huge numbers of administrators. But we can work on all of these, and so hopefully turn us from a huge outlier country into a much more normal country in terms of the cost of medical care. What we probably can't stop is the steady rise on expenditure in health per capita as time passes. We can't stop this because it is a fairly natural thing that back in 1650 or so, something like 75% of everyone's budget was food. And of that food, maybe 70% was raw calories and nutrients, and 5% was making it a little tastier and a little warmer. And as time passes, as we go richer, as agricultural productivity increases, well, now we're down to a country where there are right now fewer farmers and farm laborers in America than there are gardeners, groundskeepers, and growers of ornamental plants, and in which the sheer calorie part of what we eat is perhaps 3% of GDP. Although the presentation and someone else cooks and washes up and makes it tastier, that's still around 12% of GDP for total food budgets of 15%, both at home and away from home. And as the food share of total spending falls, something else has to grow. The same for clothing. That among the Junker class of 19th century Germany, I got this from our ex-chancellor Berdahl, who was a European historian. Among the Junker, the noble landowning class of late 19th century Germany, your average noble family had only one dress that was suitable to wear to Berlin, to the king's palace. So at any time, only one female in the family could go to parties, could go to the season, could show up at events, simply because dresses were really expensive. The country was poor. Even the nobility were relatively poor. We now have enormously greater numbers of clothes than people do back in the old days when the whole family would have one dress, and when someone would be lucky if they had 3 shirts. But we spend a lot smaller share of our income on clothing than people did back then. Shelter, we spend about the same amount on shelter, but we have much better shelters than we did back then. And what else is left? Food, clothing, shelter, entertainment, transportation. These things are going to fall over time as we find that we have enough food, enough clothing, enough shelter, enough transportation. Pretty soon we'll find that we have enough in the way of entertainment. You don't have that many eyeballs, and there are only 24 hours in a day. So why not what's left? And what's left is inevitably the only thing that can actually gain you more time, which is medical care. Keeping you healthy, keeping you active, keeping you alive. That's almost certain to grow as a share of GDP, or at least grow as a share of GDP into some far future in which our brain states are all uploaded into giant computers floating in space somewhere. So to say that we're going to freeze the rate of growth of healthcare spending, or even that we're going to keep the rate of healthcare spending from growing as a share of national product, that say we're going to keep Medicare costs per beneficiary rising at the rate of the consumer price index, as Republican Paul Ryan does, or even at the rate of GDP growth. That seems to me to be a fundamental mistake and to produce a world we really do not want. Because as we go richer along other dimensions, what do we want to spend our money on? Well, controlling global warming and healthcare are kind of the last two things where additional spending always seems worthwhile. And yet putting caps on those spending categories is something called for that seems to be a significant mistake. And then in addition, there are all the other general drivers of high and rising healthcare costs that appear to happen more or less everywhere, pretty much in every country. That is, in every country, you see patients are ignorant. They don't know what the treatment is. They don't know whether it's cost effective. They don't know whether it's a good bargain for their money. Maybe if someone has broken their hip and they're 93 and they're lying there, and you tell them, well, either we can let you kind of gradually die over the next week, or we can pump you full of fluids, pump you full of drugs, put you in physical therapy, and give you an extra 6 months of kind of hobbling around trying to recover before you die. Oh, and by the way, it'll cost an extra $200,000. Maybe if we give people the chance between, say, living for an extra 6 months in a hospital with substantial pain and drugged out when you're not in pain at a cost of $200,000, or taking that $200,000 and planting a bunch of trees, or establishing a school in your name in somewhere in Peru. Maybe then patients would be able to make informed decisions about whether to spend more on medical care or not. But those situations are quite rare, and most of the time the patient will say, well, what doctor, what do you recommend? And the doctors don't think that they're in the business of making life or death decisions, end-of-life decisions for patients, especially because patients care a lot. So there's a tendency for healthcare to simply vacuum up whatever money's left. There also is the fact that technological progress is expensive, in large part because doctors are focused on medical researchers are focused on figuring out how to save and extend lives rather than on how to do things much more cheaply. That Thomas Edison was interested in producing marvelous new capabilities, but he was also interested in saving money in their production. Pharmaceutical and researchers, doctors, healthcare researchers are much more interested in saving lives and extending lives. It's only rarely that you get a segment of the healthcare market, like as I said before, laser eye surgery, in which doctors have a strong incentive to figure out how to make it more cheaply. And of course, we said before, there's a knotted role of insurance. And all this has led to our situation with little correlation between cost and outcomes. It has also led us to a system in which there are really 5 different sets of programs or money flows that make up our healthcare system. The first is the federal program Medicaid for the poor, for the disabled, but also for the old who didn't used to be poor but are now poor because all the Medicare copays have taken their money in their house. There's Medicare, which is for people over 65. There are those people like me who are lucky enough to work for large businesses that then bargain with insurance companies over covering the whole huge honking Berkeley staff and faculty. Then there are small groups and individuals who have the problem when they go to insurance companies of facing the question, why do you want insurance? Are you sick? If you were healthy, you really wouldn't want to pay us premiums for this year, would you? You'd want to get insured next year. You're probably sick. Should we insure you? And then over and above that, there are people's out-of-pocket expenses. And there's the question of what is to be done, not so much to keep healthcare spending costs from growing, but at least to get us a program, a system that's more efficient and less cost overrunish relative to other countries than the system that we have. And right now on the plane, there are, say, 4 plans at the moment. The first is the Obama plan, the one passed last year, a year ago, which really is the Romney plan, because it was Mitt Romney's plan when he was a Republican politician when he was governor of Massachusetts. He passed it, he got it enacted. The Obama administration decided in 2009 that this model had to attract the support of a bunch of Republicans because one of the leading Republican presidential candidates had made it his baby. But no sooner does Obama embrace it than Mitt Romney and the whole Republican Party kind of pretends that they never heard of it, never thought of it, never enacted it, never thought it was a good idea. But this plan seems to have 4 pieces, the first of which are the health exchanges. Which is basically that if you're an individual or in a small group and you don't have a large business to serve as your agent in bargaining with insurance companies, that the government, or rather the health exchange, will bargain for you. To eliminate the difference between those people who find it easy to get insurance who work for large companies and those people who find it hard that don't. The second is a big push for evidence-based medicine, to actually collect an awful lot of data on what procedures work, on what procedures don't work and are costly and destructive, and what procedures do work but are so expensive and so painful we really would rather not if we understood what the likely outcomes were. For which I think a bunch of back surgery is a good candidate, as people seem to recover from chronic back pain about as well as they do nothing, as if they go under the knife, and going under the knife is expensive. And then, in addition, there are 2 more parts of it. There's the Independent Payment Authorization Board to cut the growth of Medicare spending, hopefully by gaining control of the DRGs away from the specialists and rationalizing them. And then there's this huge honking tax on high-cost health plans to give insurance companies the incentives to produce more efficient and lower-cost insurance policies. Whether this will work or not is unclear. These all seem to be good ideas. That's the Obama plan. Then there's the Republican plan, the Paul Ryan plan, whose first plank is to repeal Obamacare. So everything that's in Obama and that was in Romney care is now out. And then it's completely unclear what the rest of the plan is, except it's to gradually, over time, get rid of Medicare. That instead of having the over 65 covered by Medicare, what will happen, it would be the government would write everybody over 65 a check and say, go out and buy health insurance. And if you think that individuals have problems buying health insurance when they're in their 20s and newly graduated from college and relatively healthy, 65, 70-year-olds have much bigger problems. Because some of them are